mentoring program that is designed to engage with communities on that particular type of media by bringing together different health care provider types. In our case, it's hospice providers and subject matter experts to present brief lecture or case-based learning to really foster an all learn, all teach, bi-directional education exchange. So you as the participant hopefully will not only soak in the knowledge, but will give you a chance to extend some of your thoughts out today in this case presentation as well, and we'll give you a chance to talk about some recommendations that you may be able to provide during the case presentation as well. Hope, as the coordinator, will give you some housekeeping tips in a little while about how we're going to facilitate that. The key of the ECHO model is a hub and spoke model that the hub has, and we as NHPCO will be the hub. We will help to build a spoke structure that will extend off of us as knowledge sharing networks that are led by expert teams who will also then facilitate this video conferencing virtual case presentation or clinic with their community providers. So this is our mock session or our test run of using Project ECHO, and we are planning to bring this to you on a regular basis. So Project ECHO is going to be an integral part of the Quality Connections program and is going to focus on helping providers find or identify and find those opportunities for clinical or operational quality improvement. And we feel by either a provider bringing a clinical focused case study or an operational or process focused case study to the ECHO environment, it will allow the review by your peers and subject matter experts for that learning exchange to happen, and identification of possibilities for process improvement and identification of best practices.
Hi, Jennifer. Can I interrupt for a second and just remind everyone to put yourself on mute if, while Jennifer is presenting here, and unless you're speaking, we have enough people on this call. We probably need everybody on mute. We can hear someone talking in the background. So thank you.
Thanks so much, Lori. So the structure that we're going to be utilizing for our case study presentations is the SBAR model. And this is a model that was developed by the Institute for Healthcare Improvement for exchange and communication of clinical-based information. We're adapting that to use for our case studies. So the S is stands for situation, B is for background, all of the pertinent information that relates to the situation. Assessment is the analysis and consideration of options, and then R is the recommendation. When we look at or we hear about today's clinical case study, which was brought to us by Hospice in Illinois, we have the issue of possible drug diversion. And when we look at evidence-informed strategies, there are some things that you may be doing that really hold with best practice in this type of situation. So proactively educating patients and families about safe and effective use of medications, which includes how to take them, how to store them, what the side effects might be. All of those items go into that education of patients and families. evaluating for drug diversion risk. This is something that you may be routinely screening for as a risk in the home. Or I know that some hospices I've spoken to in the past only really screen for it if they know it's an issue or they've gotten information from a referral source. So I don't think there's a standard practice in place that is being utilized, but evidence-informed strategies really suggest that evaluation for drug diversion could be integrated into your assessment tool. And there are some tools that you can consider, such as the opioid risk tool, the addiction behaviors checklist, and I'm sure there's some additional ones out there as well. Monitoring medications in the home, this really dovetails with completing a medication reconciliation on every home visit, which I hope everyone is doing out there. And then providing specialized staff training on risk mitigation if there is identified drug diversion happening in the home. Again, staff shouldn't be going in there without, into those types of situations without being trained on risk diversion techniques and management. And also, you should be teaching them how to educate their families in a standard fashion as well. The plan of care is a consideration because all of the interventions that are implemented for the patient and family should be included in an individualized plan of care, which is stated here as one of the Medicare conditions of participation. We need to be including all of the identified problems and issues and what interventions are going to be put into place to manage those problems and issues. And also, we need to make sure that the plan of care is individualized, interdisciplinary, and contains measurable goals. So when we're looking at some standard care planning strategies for drug diversion, you're identifying the issue, you're establishing a medication safety agreement with the patient and the family. You're doing things like doing short deliveries of the targeted drug. You may install a lockbox for security of the targeted drug. You're developing clarity on what next steps should be taken. You're developing a plan for the patient and the family that revolves around both patient, family, and caregiver safety, as well as staff safety. And you're including interventions and measurable goals in that patient's plan of care. And I've identified here 2 wonderful resources from PC Now. We just happen to have 2 subject matter experts on this call that represent that organization. And they were wonderful enough to suggest presenting these 2 resources. The other issue may be in a situation where there are a lot of issues such as drug diversion, safety issues, is considering discharge for cause. There are only a finite amount of reasons where a patient can be discharged by the hospice. And that is if the patient moves out of the service area or transfers to another hospice, or they enter a non-contracted facility. The hospice determines that the patient is no longer terminally ill. And the last reason would be that the patient is determined to have disruptive behavior to the extent that the plan of care cannot be implemented. So what the regulations say is that a hospice has to determine what does patients or other persons in the patient's home behavior being disruptive, what does that look like? What does uncooperative look like? And you need to define that in your policy and procedure. You need to, when you develop your policy and procedure, you need to apply it equally to all patients. And before discharging that patient, if you're going that route for a discharge for cause, you need to make sure you have all your boxes checked. Advising the patient that a discharge for cause is being considered while you're doing your mitigation action is really important. You need to make a serious effort to resolve the problem that is presented by the patient's behavior or caregiver's behavior in the home. You need to document all of the efforts that you've made to resolve the problem and what the outcome of the efforts were. Enter that documentation into the clinical record. And just a reminder that discharge for cause can never be initiated for a financial reason or because your team happens to not like that patient or the family, that they may be high maintenance or you're just frustrated with them. So I wanted to just give you an idea of who our subject matter experts are today. They're going to have a chance to introduce themselves momentarily, but we have a very well-rounded panel today with a very experienced nurse. We have an experienced physician and two very experienced social workers that are going to sit on our panel of subject matter experts today. So Hope, I know that we need to say a few things about disclosure. There are no disclosures to make at this time, and I think now would be a good time for you to tell our participants how we're going to handle their interaction with our case presenter.
Sure, and it was great that Lori could jump in there at the beginning and take care of one of our housekeeping rules, which is if you're not speaking, please be sure that you have yourself on mute. That'll keep down the background noise. We do have about 125 people on this call, so we're going to try to keep this as manageable as possible. If you have the ability to turn your camera on when you have a question or just to interact with us so our presenters can get some visual feedback from you guys, that's great. If you're driving or listening by the phone, we completely understand why your camera would be turned off, and we respect that. If you do have a question, there are two ways to go about this. You can either go ahead and put your questions in the chat box, and myself and Lori will be monitoring that chat box for everybody. Or feel free to unmute yourself, announce yourself, and we'll do our best to keep this as clean as possible, because I'm not seeing the hand raise function that's sometimes on webinars. Lori, are you seeing that on your side? No? Okay. So that's okay. So we'll just go ahead, and if you have a question, feel free to unmute yourself, say hi, introduce yourself, and we'll call on you from there.
Excellent. Thank you so much, Hope. So at this point, I would like to do introductions, and I'm going to start with our case presenters today. So Connie and Brandon, could you please introduce yourselves?
Hey, good afternoon. I'm Connie Lemon. I'm a registered nurse. I'm executive director at Uplifted Care. We are a 38-year-old hospice, community-based nonprofit, about 50 miles south of Chicago. Brandon.
I'm Brandon Kronk. I'm a RN case manager for Uplifted Care, and the patient in the discussion is my patient.
Thank you so much. And we do have 4 subject matter experts. So I'm going to ask Roseanne Berry to go ahead and introduce herself.
Roseanne, you're on mute.
I was being so compliant about muting, I forgot to unmute.
Thank you, Rosie.
So anyhow, we provide consulting services to hospices across the country on regulatory, operational, quality issues. And what I'm excited to be part of this is to bring a fairly broad spectrum of, with hospices of all different sizes across the country and the challenges that you can face. So happy to be here.
Thank you, Roseanne. Bernice?
Hi, Bernice Burkhardt. I am the Chief Medical Officer for Merrimack Valley Hospice in Lawrence, Mass. We serve Mass, New Hampshire, and Maine. And I serve on the My NHPCO Physician and Advanced Practice Provider community as well. And I am excited to be here. Thank you.
Thank you, Bernice. Katie?
Hi there, good afternoon. My name is Katie Vogt. I am the Palliative Care and Hospice Coordinator for a hospital within Advocate Aurora Healthcare in Wisconsin. I'm also the Vice President of Palliative Care Network of Wisconsin. So very excited to be here today with all of you.
Thank you, Katie. Elena?
Hello, everybody. My name is Elena Scher. I'm a support staff supervisor at Horizon Home Care and Hospice in Wisconsin. And I'm also a board member of the Palliative Care Network of Wisconsin.
Thank you, Elena. So Connie and Brandon, I'm going to ask you to go ahead and present your case. While you're beginning to do that, I'll bring up your case sheet.
Okay.
Just a
Okay, Con-
reminder not to forget to unmute.
Here we go.
I'm just waiting for the screen share. There we go.
Okay. See if I
Okay,
can
so
increase
that's
the-
teeny tiny. Yes, my
Yep, I'm gonna
bifocal vision
see
needs
if
a
I
little
can-
larger. Thank you.
Uh,
So we decided to present this case because we were interested in feedback from others on how you would handle the same situation. So we admitted a 45-year-old male with a diagnosis of lung cancer with bone mets that was referred to our hospice on 10/13. He had previously been on our own palliative care program. And then details emerged at the admission that he's now currently wearing an ankle bracelet on home arrest. And so he told the admission nurse that it was for minor theft, but upon further investigation, more details were discovered. He had been arrested for assault, theft, drug possession, weapon charges, and he has a very long list of priors. So further details on his medical background is that he's a PPS of 50, pain rated typically 3 on a 10 out of 10 basis, morphine 100 milligrams ER BID, morphine IR 15 milligrams every 6 hours is needed. On admission, he wanted to stay full code. He initially requested nurse visits twice a week, CNA twice a week, and massage therapy. But on admit, he also was living in an apartment with his mother in a neighborhood with very high crime, frequent daytime and nighttime shootings, and drug dealing. So following the admission, during the admission that we noticed a lot of traffic in and out of the house, people outside the home appear to be dealing drugs right in the driveway, various knives, pipes, clubs, and other assorted weapons laying around the room. Mother was sitting on the porch and most of the foot traffic appeared to be stopping to talk with her. Another person in the home left as soon as the nurse arrived. Patient's ambulatory, pain controlled with current medication, able to complete his own ADLs, continent of bowel and bladder. Patient initially stated his ankle bracelet was coming off in a week, which turned out not to be true. So we had a care plan meeting the day after the primary nurse had made his initial follow-up visit. So it was with the primary nurse, with myself, with our clinical director, and we came to the following decisions. So first of all, the patient's independent with his care, so the CNA was not offered at this time. The massage therapy is non-core. So we decided not to offer that because of safety issues in the home and not have any more staff in the home than necessary until his condition warranted the need for symptom control with massage therapy. The patient's symptoms are managed, so nursing visits are going to be made weekly to start with, and of course PRN if needed. All visits are going to be made in tandem with another staff member. So we were incorporating our social work and chaplain visits into this, doing joint visits with the nurse to get all disciplines in, but to do those visits jointly. We don't have private security company services available in our community. Our metro area is about 60,000 people. And so we did use our police force, which is very cooperative with us when we need to make joint visits with them. So they did accompany us on visits.
Okay, Brandon,
And then
did
we
you
have
have,
an addendum to that as well. I don't know if you have that on there.
I don't think I saw that.
I can pull it up real quick here. So, so the recommendations that also came out of this meeting were to put in a medication lockbox with the patient managing the key. He was deemed reliable for that. Visits are made during daytime hours only unless there's a PRN need. Safety agreement was signed with the patient with the hospice social worker as a condition of continued care. So that was 2 hospice staff, and the police escort will be used for all visits, while staff members staff members are present, there would be no illegal drug use or drug diversion of hospice meds. Prior to the visit, the family is notified that any weapons in the home must be secured and not visible. Patients required to assign the agreement and remain compliant or be discharged for cause. So he's a very motivated patient wanting to stay out of jail. He did sign the agreement without argument, and he remains compliant with medication use and conditions of safety agreement. So our resolution here was that since the admission, there have been no incidents that have occurred during visits, no narcotic discrepancies. We do a narc count every single visit. The patient's motivated to stay on hospice as a condition for not going to jail. So his sisters are very involved and cooperative with his care and with staff. The patient did move to a new location on November 15th to be closer to the one sister for care when he declines. And his new neighborhood's a little lower in crime. So we are doing still visits in tandem, but didn't feel the police escort was necessary unless we do a nighttime PRN visit. PRN visits have been made without incident. The patient has now decided to be do not resuscitate. And he still remains a PPS of 50. Symptoms are managed with the current treatment plan. And his treatment plan will be adjusted as this condition warrants, including increase in frequency of visits and additional disciplines. One request he had of us, which we declined, was he wanted a letter by our medical director saying that due to medical reasons, he wanted to have his ankle bracelet removed by the court, and our medical director refused to sign that because there's no medical reason for him not to wear the bracelet. He did sign a letter for him for the court, though, stating that he is terminally ill and requires the services of hospice.
Great, thank you. Brandon, anything to add? Is Brandon on mute?
Yeah, I'm here. Am I still muted?
You're fine. Nope, you're muted. There you go.
Okay. The only other thing I would add to that is recently he did have a medication change where the morphine extended release was increased to 100 Q8 hours. And we're not making available liquid morphine in the home. So he has only the IR and the ER in tablet form at this time. And he's getting a 1-week supply.
Okay, great. All right, so I'm just going to take a minute to do a quick summary to make sure we understand all the points. This is a 45-year-old patient with a terminal diagnosis of lung cancer with bone mets. He came on to hospice service about mid-October, and he does have an ankle bracelet in place because of incarceration for a minor theft. There are some issues, it looks like, with weapons and possible drug dealing and drug diversion in the home. It looks like he has a lot of traffic coming in and out of his house. For his status, though, he seems to have his pain controlled. He is able to complete his own ADLs. He's continent of bowel and bladder. And he recently had a change in his pain medication to continue to manage his pain and keep it under control. It does look like the interdisciplinary team has been coordinating for safety reasons since the patient lives in a higher crime neighborhood, to make sure that the staff is safe when they do go to see him. Restricting some non-core services is in place as well as some other precautions such as short medication deliveries and installing a lockbox into place. And it seems that there has been a move of the patient's residence in order to assure that there is support from a family member when his condition does indeed decline. So at this point, I'm going to put the agenda back up, and we are going to invite questions from both participants and our subject matter experts. So let's go ahead and
Hey, Jennifer,
sorry.
this is Lori. I wonder if it would be better to just leave it full screen for participants and not have
Sure.
the agenda up, just because I think it might.
We could absolutely do that.
facilitate. Thank you.
So as Hope mentioned a few moments ago, you can either put your questions into the chat, and Lori is going to be our question extraordinaire reader today, or you could go ahead and unmute yourself and ask Connie and Brandon any questions you might have about the case.
Well, this is Roseanne. If I can go ahead and start with your questions. Tough situation. I'm sure many hospices have run into this, and it's a great one for us to have the opportunity to kind of chew on. Sounds like you've done a lot of things right. I guess one of the questions I have is, now that he's moved someplace that's a little bit safer, how does staff feel now about the safety and the fact that you don't have, I think I heard you say you don't have the police escort going in with them. So how does staff feel about that? And directly related to that is, when you do have to make an after hours visit, when that time comes, if it comes, then how do you plan to have a safety for the staff when it's dark out there?
Okay.
Oh, Connie, you're muted.
I'll start and then
There
let
you go.
Brandon, okay, I'll let Brandon kick in here too. But at night, they will still be using police escort. So
Okay.
I wouldn't call it a completely safe neighborhood yet. It's still just in a different area of the same town with less, shootings and things going on, but still an active neighborhood. So, so the visits are still joint. We do have a device called GPS Alert that our staff checks out to use when they're going into areas they have concerns about. As long as they've had the police escort, they haven't, they don't use that because they already have the police with them. So we do have all those things. So at any time, and again, our police is so cooperative here in this community to step up when we call them. We call about 15 minutes ahead of the call, and they meet us there and do the visit jointly with us. So Brandon, I'll let you go ahead and chime in on how you feel safety-wise going in with without the police escort during the day.
In terms of feeling safe, I think I've established a relationship with the patient where he knows that based on the agreement, what the expectations are, and going into the neighborhood is the first priority. Really, there's no other houses around him. Where he was living previously, he had a lot of houses in a very congested area with a lot of foot traffic outside the home. Currently, there's not the foot traffic available. I do feel that the patient receives a lot of benefit from the joint visits as well. Being able to have, a lot of times it's done with the chaplain, and he enjoys the spiritual support. So we've kind of turned it into a positive thing for him. He also allows me to call him ahead of time, like at the beginning of the week before his scheduled visit to review his medications over the phone. And he will actually do a brief narcotic count, so I have an idea of what he's been doing since the last visit. I really have not seen any weapons in the home since he's relocated. There's also smaller children in the home as well. It's more of a family situation now versus before it was just him and his mother in an apartment with people coming and going all the time. And he's been very respectful of narcotic counts. He has his meds ready for me every time I go over there, even when he's in pain and can't get out of bed. He understands that. So safety-wise, I feel very safe going into the home, but I still, because of the unpredictable nature of somebody else wanting to do something to him based on his criminal history, that would be my biggest concern at this point.
We had a question in the chat. Connie wondered if you could share more about the GPS system that you're using.
Sure. It's a product called GPS Alert. You can Google it, or I can get information out later on that. And it's a device that they wear around their necks. The staff does, like a life alert. We have them for all the on-call staff, and then we have extra for PRN use of staff can just come in and check it out. And it's a device where you press the button. You can set it up in different ways. So we have it set up so that only the person that's wearing it does the talking. And the reason for that is that, you know, you don't want a voice coming back out of the voice box, and in a situation where you don't want the patient or an unsafe situation to know you've called for backup. So you press the alert and you hold it for a few seconds, and then you just start talking. And you could say anything from, I'm in a serious situation, I need the police, or if you don't want the person, the patient, let's say the patient's being unsafe towards you and you don't want them to know you're calling the police, you just start talking, and that operator knows you're in trouble. If you've pressed that button, they know you're in trouble, and it's a silent alert, and they send the police over. So it's a great device. I think it's around $25 a month per device, plus we had an upfront cost for it to initiate it.
I would invite the other subject matter experts to go ahead and ask questions.
Yeah, this is Bernice Burkhardt. I do have a question. I see that the patient medication delivery is a week supply at a time. I know that I've been in situations where we've been able to coordinate with our pharmacy to give 3-day supply at a time. What was the consideration there in terms of the length of the number of pills or supplies? And a follow-up to that question is, was any consideration given to transitioning the patient to maybe methadone as a long-acting agent as opposed to the morphine?
And then I'll let you take.
So in terms of the morphine and why we went to the week delivery, we originally had him on a 2-week delivery, and he also had liquid morphine in the home. So the narcotic counts were consistent, but the patient was getting confused about which short-acting morphine he should be taking, pills versus liquid form, thinking that one would work faster than the other. So we eliminated the liquid morphine and went to the 1 week because it gives a good turnaround time for him to be able to manage the medications without having to make frequent visits, and also to he hasn't shown any narcotic discrepancies, but it's more of he gets confused about the medications and what he should be taking. If anything, he skips medication doses versus taking extra medication doses. So we're trying to simplify it for him, as well as keep close tabs on it so that we can monitor. And he'd been on the 100 Q12 hours with the 15 breakthrough Q6. He was on that prior to coming to us. So his first medication adjustment was to go to the 100 TID to see how that, and we haven't approached methadone at this point.
I have a question. As I mentioned in my introduction, I'm from Wisconsin, and we've had we've made national news several times. There's a lot of tension with the police and with sometimes it's our staff and also the communities that we go into. So my question is, how do you engage with the police and the patient and the community where having them present doesn't escalate a situation, but more so diffuses any potential for possible
Sure.
clashes?
And that's a really good question, because I can see where that could happen if you had a patient that was a little less motivated than this gentleman. So again, having hospice in place is a condition to keep him out of prison right now. And so he's extremely cooperative. I don't think he's had any disrespect towards the police, when they've come in, or from the neighborhood itself. We went through a little bit of the same, protests and stuff, not anywhere to the degree you did, obviously. But if there's no TV cameras there, then it stays very calm. So it's been fine. It's been respectful, and the police are extremely engaged with us. They always have been. We call their backline number and just request the escort. Again, we don't have security company backup in this area, so they do it. They don't charge us for it, and it's worked well for us.
I have another question. I actually have two. So to bounce off Elena's kind of question, is there any involvement from a parole or probation officer, and have you coordinated with them at all in the community to kind of make sure that everybody's on the same page from that aspect and you're all working together? Or is that not? I think we've done that up here in Wisconsin before, so I don't know if that's just a state standard or if that's kind of something considered in other states as well. So I'll start with that question.
Brandon, I'll let you do that. Do you have any?
I have not had any personal contact with the parole. There have been a couple instances during visits where the ankle bracelet is going off and the patient has contacted his parole officer during visits. But in terms of they are aware that he is on hospice because of the letter that was sent.
Mm-hmm.
But they have not reached out to us, and I have not had need to contact them for anything where I felt there was something in violation of the parole or something that I had a concern about.
Okay.
Going back to the question about the police officers, the patient actually was well known to the police, and they were actually very pleasant with him and understood his situation. They assisted him in getting the buzzer shut off on his leg alarm one time. A lot of times it was more that they would wait outside the door to keep somebody else from coming in the home in those high traffic areas. And I think part of his relocation may have been due to some of the people around him who wanted to engage in the drug diversion or different things. He felt uncomfortable with them being around. So the patient actually took the initiative to relocate himself in order to provide better services to him, which I thought was nice.
My second question is, what is the plan if he were to no longer meet criteria for hospice care? Is there some sort of coordination or a plan in place on how to help him transition off of hospice care and back out into what would be the next step for him out in the community?
Because of his metastatic disease, I don't see that as realistic that he would not need hospice anymore unless he was to be discharged for cause. And, in that case, we would treat him like any other discharge for cause where you put other resources into place as much as possible. But his resources, if he goes off hospice, is to go to the correctional facility and be in their infirmary. So that's his alternative.
Any other questions from participants?
Yes, I have one for all of our participants. Is this, a unique case, or have many of you experienced similar complicated cases? And if so, has the case that has been displayed today, is it common, the steps that they've taken to address some of the safety concerns with this individual. And you can share that in the chat if you don't want to speak up. But we really want to make sure that we're meeting everybody's needs that is participating. So please feel free to share.
Lori, this is Bernice. There's a question in the chat box that, I was going to ask, what was the reaction of the team to the neighborhood they were going to, and, to the fact that the individual has a police record and a visible ankle bracelet, did that jar anyone? And I guess it matches with what approaches are taken to avoid, and this is a question from the participants, what approaches are taken to avoid implicit bias when serving diverse populations in high-risk neighborhoods or communities?
Well, our first response was, how can we serve this gentleman? It wasn't, no, we can't take him because it's too scary. It was scary, it was a scary situation, but it's not unique here, unfortunately. Probably the high profileness of him is a little more unique to us, but we've had patients with ankle bracelets before. But it is just the combination of everything with him because of that specific neighborhood being so intensely high crime, daytime and nighttime. Our first concern was for our staff, obviously. And so making sure that we can safely meet his needs. And we felt like with the measures we put in place, and, of course, our staff is always directed, you don't even go into a neighborhood if it looks unsafe at the moment. You just turn around and go back out. And then extract yourself if there is a situation immediately, and then call 911. But we try not to put our staff in a situation that there's going to be a safety issue. So I think the plan was a good one going in, but would have been changed if we'd had anything come up that required changes to it.
You're getting a lot of validation in the chat. Sorry to interrupt you, Brandon. Go ahead.
Oh, I just wanted to add that a lot of the things that took place as far as interventions took place after the patient had already been admitted, and as new details came to light, because he lived in the neighborhood on admission, but it wasn't until after the follow-up visit, and I had been in the patient home and I had seen some weapons, and it was more of a as stuff was happening, rather than because he lives here and we need to take, he has an ankle bracelet. It was the degree kept escalating based on more information. So the care plan had to be developed based on that.
So I'm going to make a call for any final questions before
There's another one in the chat. Yeah.
Okay.
Was there a delay from referral to admission due to the circumstances of staff safety?
No, because like Brandon said, we weren't really aware of this. We think that the crime that he was under arrest and being going to be jailed for was very, very recent, because we'd had him on palliative care for a while, and this had not been an issue. So it was a recent crime that brought it right to the, that he was sitting with the ankle bracelet on, and so no, we didn't. It wasn't something we had awareness of before we admitted him.
Connie, do you think the fact that he was a palliative patient for you already helped your acceptance of the situation?
Yeah, because we had a little bit of a track record with him, so we knew the situation.
So I have another question. Brandon, you've done a nice job developing a relationship with him, but I don't think you work 24/7. So how do you address it when you are off? I mean, I think your idea of calling ahead of time, and actually it sounds like what you did is you're actually starting your visit before you got there, kind of getting everything in order. Very, very smart. But how does that happen then when you're not there? How does the care plan address that? If I was taking call or if I was covering for you, how would I know I should call first? How would I know if I'm the on-call person, it's not a safe neighborhood, I do or don't need a police escort? How does the care plan kind of direct that, drive the car?
So when you pull up the patient in our charting system, the demographics page comes up. All of that information is located at the top of the demographics page with instructions about safety, when to do visits, how visits should be done, calling ahead of time for any unscheduled visits, because the patient still does leave the home. So if for any reason someone needs to go over there, all those instructions are highlighted and at the top of the demographics page for him.
Terrific.
And we have had two PRN visits. One was, I believe, conducted at night, and one was conducted during the daytime, and this was prior to him moving. Both visits went out with had no conflicts, no problems, and situation was resolved pretty easily.
Good.
Okay, any final questions before we move on to recommendations? All right, so I will now invite our subject matter experts, given all of the information they've received, to make some recommendations to Connie and Brandon. Who wants to start?
I can go first. I think I can echo what a lot of people have put in the chat box, which is an affirmation of your handling of this case as being thorough, right, and well thought out, and considering all of the different permutations that can happen. And I think this was further elicited when I asked my follow-up question on the timing of meds. Clearly a lot of thought, even as it was developing, right, that rapid response that you guys had in the development of a treatment plan that put the patient first in the center of it while maintaining your staff safety and allowing them to do the jobs of caring for the patient. So, I mean, I don't really have new recommendations when it comes to the medication management, right? Again, you know, the frequent and consistent med reconciliations, I think, are going to be key to make sure you're not missing anything. You also have a very cooperative patient, which is fantastic, who understands the implications. You've communicated clearly, you know, what next steps would be if these things the conditions aren't met. I think that's a big piece of it that we don't miss out on, but I think, you know, in our heads, we know what the implications are, so we don't always clearly delineate it to the patient. We sometimes assume they understand it. So again, all that was done very well. The only question I have, it wasn't written down, right? But of course, all this was documented, no doubt, in the medical record. So again, I have no recommendations as to the medication management because it seems appropriate and well thought out.
Thank you so much, Bernice. Who would like to be next?
I can go next. I also agree with Bernice. I think you have done an excellent job with the situation and kind of planning out. And, you know, it's fortunate that he's very cooperative and willing to work with you as well. I think if not, it might be a little bit of a different scenario, but you've done a great job from what I've heard. No real recommendations. I feel like you've contracted for safety of your staff and of the patient. I think that's great. I think, you know, maybe the only thing is if there were to become a little bit more of that implicit bias or unconscious bias from team members, making sure that there's some education opportunities there to just ensure that there's no bias going in before. But it sounds like you've done great with all of that as well. And I really like that GPS idea. I think that's a great thing that you have available to your staff.
Thank you, Katie.
I'll go next.
Okay,
Yeah.
go ahead.
I again am kind of just echoing everyone's sentiments. I think a really great team approach. The fact that you have incorporated the chaplain not as a way to kind of monitor and but actually engage with the patient. There's obviously a cultural component where the patient feels comfortable with you, with the chaplain, and even with the police, that it's been a successful coordination of care. So a job well done.
Thank you, Elena. Roseanne?
Yeah, sure. same echoes about what you've done from a care planning perspective and being proactive. And the only recommendation I have, which I think you've probably already thought about, is to continue to be proactive, because as he declines, and we know with lung cancer, you can't have the brain mets, so we know to increasing medications, there might be some cognitive decline along with that. And so then how does that change? Who's his medical power of attorney? How long does he want to stay where he is? I mean, sort of what's the plan from a proactive perspective? He is being cooperative now, but as his mental status perhaps could deteriorate, so then just kind of keep that, okay, what's next? Proactive care planning going on. What could be next?
Very good.
Do we have any recommendations from our participants? You can put them in the chat or unmute yourself.
There is one question in the chat from Gail, and it's, if staff engage the GPS alert and need police assistance, what is the response time? Or does it depend on the location?
Depends on the
Have you had
location.
to? Okay.
Mhm. Yeah, we had an instance one time we were out in the country, and so it was a little longer. It took about 20 minutes. And in that case, the family was very angry that we'd initiated that, but it was a very hostile situation our staff were in, and rightfully so, they hit the alert, just to get themselves extracted without harm, and I don't think, there's no way of knowing if the family, but it was just a very, volatile situation that we needed that backup for. So it's nice to have that if we need it. For sure. But again, it's like getting like your own on-call systems, like where are you located and how long will it take somebody to get there? If you're in town, it would hopefully be 3 or 4 minutes. If it's out in the country, it could be quite a longer time.
Thanks, Connie. All right, so I'm just going to do a quick summary of the recommendations. It appears that, yeah, kudos, and I agree, are to give in to you and your staff, and Brandon, to you as well, with doing excellent coordination in a very complex situation. There were just a couple suggestions. One, if implicit bias does develop along the way, there's a suggestion to educate your staff about that, and continuing to be as proactive as possible as the patient's status declines, to make sure that your plan of care encompasses all of the interventions needed to manage the patient's care as this decline happens. And another one, it wasn't provided so much as a recommendation, but coordinating, if it became a case, coordinating with a parole officer related to the plan of care if that's necessary. So I'm going to ask Hope to do a couple of finish up on any housekeeping that we may need to inform you of.
Sure. Hi, everybody. So we probably should have said this at the beginning, but all of this has been recorded. If anyone is against that, please shoot us an email at qualityconnections@nhpco.org. And we will post the slides and recording, unless I hear anything from anybody, to a library that we are forming on the NHPCO website. All of you guys, participants, will receive an email about that, along with an evaluation to let us know how this first echo session went. So please give us your feedback. And then for the year 2021, we are collecting case studies. So if you have any unique or interesting cases that you'd like us to discuss in a format like this, please send those over to qualityconnections, with an S at the end, at nhpco.org.
Thanks, Hope. And we are just about finished completing our Project Echo webpage. So we'll announce when that webpage is up. We'll have all the information about Project Echo and what we're planning to do here at NHPCO, as well as access to that SBAR form. If you are interested in submitting a case study, we would ask you to grab that form and write your case up on that SBAR form, and then go ahead and send that to Quality Connections nhpco.org. So watch our communications for the call for case studies. Or if you're interested in just shooting us an email and asking us questions, you can do that at qualityconnections@nhpco.org. So I would like to thank Connie Lemon and Brandon Kronk as our presenters today, and Roseanne Berry, Bernice Burkhardt, Elena Scher, and Katie Vogt as our subject matter experts for our mock Project Echo session. Thank you so much to all of you who called in today to participate as well. Come back and visit us again when we start our regular Project Echo sessions in 2021. Thanks so much to you all and happy holidays.
Thank you.